I'm just going to go ahead and jump in. The first case is a 66-year-old gentleman presenting to the VA, and he really only has a past medical history of COPD. When you admit him, he's coming in with 10 days of dyspnea and cough. He was confused when you go to see him, but fortunately his wife is at bedside, and says that she brought him in because he's coughing, but she's noticed that he's been having a hard time swallowing, has lost significant weight in the last year, and has seemed to be more confused, less with it for the past 18 months. He has a social history significant for a 25-pack-year smoker, occasional alcohol use, no illicits, and his only medications are tiotropium and albuterol. What else do you guys want to know? I might have you unmute yourself. I'm trying to pull up the chat. There we go. Yeah. Okay. Any other questions you have before you examine this guy? Dysphagia to solids versus liquids. Excellent. Like the first thing you always ask. So it sounds like it seemingly started with solids and now he chokes with most foods. Ever received lung cancer screening with low-dose CT? Another excellent question. No. He's kind of a very, I would say, typical vet. Comes to the doctor when he's supposed to, not eager to get any extra CAT scans, and says he feels fine. He knows he doesn't have lung cancer. What? Okay. History of reflux-like symptoms. Excellent. So that's a really good question. Always incredibly important to ask when you're seeing anyone with dysphagia, difficulties tolerating swallowing of any kind. We don't know. His wife says he doesn't take Tums. It does sound like this is a pretty new cough. Okay. Any diet? Yeah, excellent question. So sounds like he doesn't avoid any foods. He's been eating really small bites, chewing for a long time, trying to help this dysphagia. His wife says that it seems like he just gets frustrated with eating before he gets full. And she thinks that's why he's been losing weight. What are you thinking about when you ask about diet, Ace? Possible vitamin deficiencies. Excellent. So it's kind of gave it a little bit away when I say not enough of a good thing. Perfect. And are there any specific questions you guys like to ask about diet in particular to help screen for big deficiencies, or do you ask more just general questions? Enriched grains. Yeah, excellent. I think that's always a good consideration. If people are eating only white bread, no, it's important because everyone, according to a lot of like pediatricians I know, as long as you eat enriched grains, cereals, whole wheat bread, it's hard to get mineral or vitamin deficiencies. However, if you're eating only white bread, specifically like Wonder Bread that might not be real food, then you run a higher risk of getting having vitamin deficiencies. So unless there's anything else, I'm gonna jump into the physical exam. I'll try and keep an eye on the chat here. So taking a quick look at his vitals, he is tachycardic, blood pressure is normal. Low O2 sat though, requiring 3 liters to get up to 95%. Overall, he's a hectic, anxious appearing gentleman. Pupils are equal round, reactive to light. You can't really get him to focus to do a full cranial nerve exam though. He's got moist mucous membranes. He does have rapid rate, regular rhythm, good distal pulses. In general, he had a poor inspiratory effort with bivascular rails and was really alert and oriented only to person, and he knows that he's at the VA hospital. Any other questions on the exam finding? Okay. Great. So what I'm pretty sure what's the next or one of the first tests what tests you want to get in this guy? We'll get a BMP, a CBC, any imaging, things like that, peripheral edema, JVD. Excellent. I think thinking about heart failure, he did not have peripheral edema. He's a pretty thin guy. I think his BMI was like 18, 19, and no JVD. Let's see. So I'm going to throw up this chest x-ray that we got based on the history of cough, dysphagia, and a low O2 sat on admission. I'll give you guys a couple seconds to look at it here, but I don't think it's a real secret finding. Someone want to throw into the chat what they see? It's not a trick, I promise. Let's see. Anyone have, oh, right, plural if you, yeah. Perfect. Yeah, I love the UCH. It's hard to tell. There's probably an element of effusion and definitely some lower lobe consolidation. Right, yeah, the right hemidiaphragm is tough. A full disclosure, this is not this patient's chest x-ray. It was at the VA, and getting imaging remotely was not going to happen for me. But this is a right lower lobe pneumonia, which is what he had ultimately determined or attributed to acute on chronic aspiration, which is not surprising in the setting of a gentleman who has significant dysphagia and weight loss. So then after that, his labs start coming back, get gas with his COPD and poor SO2. He did not, unfortunately. I think his O2 improved rapidly enough with supplemental oxygen. He didn't have any wheezing or other findings concerning for an exacerbation. And part of it was also attributed to poor air movement due to inspiratory effort. So we also get these initial labs, and then in the first day of his hospitalization, got a screening MOCA due to this decreased mental status and history of progressive cognitive decline. So I didn't highlight the abnormal values for you here, but I think you'll see he's got a macrocytic anemia and then a MOCA of 13 out of 30. Kind of below 22 is consistent with cognitive decline. And then also an ECG, because he was coming into the hospital, that was stone cold normal. So with this information, I think it's a good time to try and do a problem representation for this patient. Remember, I think he's a 66-year-old gentleman, history of COPD. I'll give you a minute, and then if someone wants to throw problem representation into the chat. And if there's any other questions, we can talk about the next steps in evaluation as well. Okay. Let's see. Does anyone, oh, perfect. UCH, 66-year-old gentleman, 18 months of dysphagia, weight loss, macrocytic anemia, altered mental status with the right lower lobe consolidation. Excellent. So I think it's kind of tough at this point. I think that's probably almost identical to what I came up with to determine he's got a kind of subacute to chronic process with this cognitive decline, dysphagia, weight loss, now coming in with an acute aspiration pneumonia. So we'll certainly treat the aspiration pneumonia or the right lower lobe consolidation. But what else do we need to do? How else do you guys want to approach this cognitive decline? What are the next best tests that you want to order for this gentleman? What are you thinking about for him? B12. Excellent. And what specifically throws you to the B12? Perfect. And folate. Yep. Cognitive decline. Yeah. Excellent. And then what other, do you guys have other studies that you typically throw in? Reversible causes, B12, folate, TSH, RPR, HIV. Love it. That's all of the things I wanted to see. So now what? This is the additional workup he gets. He gets a TSH within normal limits. RPR and EIA were negative for syphilis. HIV was negative, and his B12, his folate, I'll say was normal. I just didn't list it here. And his B12 was significantly below the lower limit of normal, 63, with the lower limit of normal being 200. And Ace, thank you for throwing in no ammonia. Completely agree. So now we have a gentleman with a significant B12 deficiency with evidence of cognitive decline and dysphagia. If you recall from the lab slide, he has a pretty significant macrocytic anemia. The anemia is not too severe, as hemoglobin was about, I think, 10.9, but the MCV is 109. Okay, Smear, what are you thinking with that, Jordan? I think that's always a reasonable thought when we're thinking about hematologic abnormalities. What are the what other studies should we order or consider in someone with significant B12 deficiency? I think this is something I, to be honest, hadn't really thought about too much since med school, because I think we learn about it, but it's not incredibly common. So for this gentleman, he actually, in addition to in an evaluation of the dysphagia as well, got a barium swallow that had severe esophageal and pharyngeal dysmotility, delayed esophageal emptying, and microaspiration, kind of explaining that, of course she did, explaining the aspiration component. And the EGD then had severe atrophic gastritis of the gastric fundus and body and a positive anti-intrinsic factor antibody, leading to a final diagnosis or kind of summary of this patient as having aspiration pneumonia due to neurogenic dysphagia, a sequela of severe B12 deficiency caused by pernicious anemia. Full disclosure, we did do a write-up of this patient because it's a rather interesting presentation. And so I wanted to talk briefly about first, the approach to the reversible causes of cognitive decline. I say briefly because you guys nailed it. I think the big point to highlight here is that screening for depression, B12 deficiency, hypothyroidism should be done in everyone coming in with cognitive decline. We didn't touch on the depression, but that wasn't anything that was hinted at in his history. HIV and syphilis can be appropriate depending on risk factors. I think it's a reasonable standard practice to do in all patients. especially I know one of our co-residents, Sunny Stone, picked up new neurosyphilis in an 83-year-old that he admitted last year, with where we had very low suspicion for that initially. And then I love that we didn't jump immediately to imaging. This is based on the American Academy of Neurology's kind of recommendation paper, most recently from, I think it was 2001. They're working on an update. There's really not significant changes to this. But the point is that there's not necessarily a role for structural imaging if there's no focal deficits or concerning history. You could consider the 1433 protein if you're concerned for Creutzfeldt-Jakob disease, but this patient doesn't have any of the disinhibition or other chorea that might make us think of that. And there's not a recommendation to routinely test for any genetic markers, even in the setting of things like Huntington's. If patients are interested in Huntington's testing, that's reasonable. However, their position is because we don't currently have a reliable test or reliable treatments, it's not a appropriate next move. So then just to talk briefly about pernicious anemia, I had to include this graphic. I think it's just one of those beautifully simple graphics that explains exactly what pernicious anemia is. In a normal person, you eat B12, it attaches to intrinsic factor and is able to be absorbed by the parietal cells in the stomach. However, in pernicious anemia, an antibody is produced, can be to parietal cells, can be to the intrinsic factor, but preventing B12 absorption and resulting ultimately in deficiency. And I think it's, oh, perfect. Mostly curious to see megaloblastic because I like pretty slides. I think that's a reasonable, sorry, just saw Jordan's chat. I like that thought, Jordan. And I don't know if we ever got a smear in this gentleman. I can't recall. Sorry. So then just talking briefly about if you had evidence of intramedullary hemolysis, seem to recall the B12 deficiency, any neutrophil abnormal morphology, Northern European descent, more common in them as well. Of course, Dr. Chan with all of the important pertinent learning points. So intramedullary hemolysis, we did not ever see clear evidence of that. And I can't recall the smear. Don't think there was significant abnormal neutrophil morphology, but he was absolutely of Northern European descent. And in that age range, especially 60 and over males of Northern European descent are the most common group with pernicious anemia in chronic PPI use. I have not seen that. However, I will look into that, Kate, because I think that's an excellent point. And I think this is interesting because we always worry about deficiencies, I think, in our alcoholics or other people who have malnutrition. But this gentleman did have weight loss, but was not initially or clearly malnourished. So just want to talk again briefly about B12 deficiency. It's more often due to poor absorption than inadequate intake. So I think that should always be on our radar for people who he doesn't have any clear risk factors for poor absorption. He seems more that he's not getting enough intake because of the dysphagia, although he also obviously was not absorbing what he was taking. The other people in this group that we need to think about are post-gastric bypass people and anyone with abdominal surgeries that might alter the anatomy and ability to absorb. And then as a reminder, B12 is important for most specifically erythropoiesis, as well as maintenance of the myelin sheath, and so often manifests as anemia and neurogenic sequelae. And as we found in this patient, typically by the time you have neurologic manifestations, you have clinically significant or at least laboratory evident anemia, megaloblastic anemia. And then, or macrocytic anemia, sorry. And the most common presentations of B12 deficiency are dementia, delirium, psychosis, or peripheral neuropathy. And this patient was somewhat unique in that it's not commonly, they don't commonly present with dysphagia. However, it is recognized as a potential sequela of severe deficiency. Importantly, oh, interesting, which makes sense. I saw the VA team comments that B12 deficiency with increased rates of hip fracture. Certainly, if you've got peripheral neuropathy, you're at higher risk of falling, more likely to fall and break your hip. Most often we can treat B12 deficiency with oral B12, even though it's due to poor oral absorption. 1 to 2,000 micrograms daily is usually enough to overcome absorption deficiencies. However, once there are neurologic symptoms in pernicious anemia, it must be treated with 1,000 micrograms of IM weekly injections for 4 weeks, followed by monthly injections and trending of the values. For this patient, completed that treatment course and his dysphagia improved. However, his MoCA never significantly improved. It remained, I think, it was about 16 a year after this encounter. So, and unfortunately, that does tend to be the case, that once you have progressive neurologic sequela from a B12 deficiency, it's not completely reversible. So another reason it's important to think about these deficiencies sooner rather than later. Any other thoughts or questions? And I will look into the B12 deficiency in chronic PPI use. And then I do have one other case along the same lines. This case, do you have screen for gastric cancer with pernicious anemia? That's a good question, Jordan. Not that I'm aware of. I don't know if other folks have more knowledge, but I can look into that as well. So this is a shorter case. This is a 76-year-old male coming in with recurrent falls. He and his wife agree that for the past 8 months, yeah, exactly. Thank you, Sneha, perfect. So for the past, this patient, he and his wife come in and you're seeing him in the ED after he fell on his way to the restroom overnight and was unable to get up. And speaking with him and his wife, they agree that for at least the past 8 months, he's had increased difficulty with ambulation. And at the time, initially noted that he had some numbness in his bilateral feet and feels like it's now progressing up to, yes, Ace, this is just for you, and now progressing proximally in his bilateral legs pretty symmetrically. Feels like he needs increased support to walk, but hasn't seen PT or anything like that. B12 deficiency. That is always a reasonable thought and was one of the first things they screened for in him. I'm not so lazy that I did the same case twice. This gentleman's vital signs were within normal limits. And I will kind of skip or brush over his orthopedic exam that he came in with a concern for a hip fracture because he wasn't able to get up. Did not have a hip fracture, but when I think I did see him on ACE and PT tried to ambulate him, he was just unable to walk unassisted, and that's where we're meeting him. He's elderly, no acute distress. He's alert, oriented to person, place, situation, and date. He had some generalized hyperreflexia with clonus in his bilateral lower extremities, decreased proprioception, vibratory sense, and touch distal to his knees. And you do get that he has a very remote surgical history of a gastric resection. He just says, when I was in my late 20s, had a ulcer that bled and they had to take out part of my stomach. Really doesn't know more than that, unfortunately. So what are you guys thinking about now, or what do you want to do next for him? And this is tricky, which is why I'm highlighting it. Medications, excellent. So he is actually that very rare 76-year-old who took no medications. Because that's the nice thing about, one nice thing about this case, it's a little clean, but that's absolutely one of the things I know ACE always thinks about. It's polypharmacy until proven otherwise. 76-year-olds, I'm highly suspicious of medication interactions. History of gastric resection at risk for all vitamin deficiencies. Exactly. And so I think that's one of the tricky things. Copper, zinc, and ADEK. Wonderful. So this gentleman, once again, has a more mild, but again, macrocytic anemia. BMP is otherwise unremarkable. I did skip over social history. He was a never smoker, social alcohol use, no illicits, reports monogamy with his wife for the last 59 years. Lead, excellent. And the copper, zinc, and then vitamins A, D, E, and K. I think this is a wonderful approach to the labs. I think I have most of them here. So he has normal TSH again. And so just reviewing those labs we talked about previously for cognitive decline, but he didn't have any cognitive decline here. And I think hopefully I included all of the zinc, copper. Okay. So I skipped to the meat here, but this gentleman actually had severe copper deficiency, as Anita pointed out, with that gastric resection due to poor absorption. His zinc was normal, and other vitamins were normal as well. So we just wanted to spend the last few minutes. Ooh, I love this. UCH, tell us more about this denture cream and zinc deficiency. So impairs zinc absorption. Interesting. That's amazing. And because I'm sure you swallow a little bit and then impairs. That's fascinating. That's really helpful. And yes, exactly, Dr. Chan. Zinc toxicity can be a cause of copper deficiency, or even just significant, higher than necessary zinc intake. It uses a similar receptor and can just block the absorption. Also learned nutrition zinc repletion can cause copper deficiency. Exactly. And so that's one of the risk factors that I've started to cite for people who take a lot of zinc around cold season, worrying that they don't want to get colds. There was reports years ago that zinc would be helpful, but it can in high doses cause copper deficiency. And then denture cleaning liquid, we're talking about there's actually a paste that you use to stick the dentures to your gums, versus the solution that you put the dentures in. So just briefly want to again talk about copper deficiency. It most often presents, as in the case of this gentleman, with myelopathy, myeloneuropathy, and patients reporting a subacute decline in their gait and sensory deficits. You may have anemia and leukopenia, because it's also important in myeloproliferation, and can be diagnosed with low serum copper as well as ceruloplasmin. Most copper in the serum is bound to ceruloplasmin. Typically, it is due to poor absorption following gastric surgery. And then, as we've mentioned, can also be due to excess zinc intake or severely restrictive diets. And the treatment is typically 2 milligrams of elemental copper daily. Oral is best and most easily accessible, but parenteral can be used as well. And then I think the one of the important things I learned from this case is getting copper supplements can be incredibly difficult. Most of our hospitals don't actually carry copper supplements, and going to health food stores, it can be pretty expensive. But copper is actually typically included in prenatal vitamins. And over the course of residency, I think nearly every vitamin or nutrient deficiency you can overcome by giving a patient a prenatal vitamin. You can always ask nutrition and double check, but that's oftentimes the cheapest, easiest way for patients to get micronutrient deficiency relieved. And then, as with severe B12 deficiency, treatment and repletion will typically stop progression of symptoms and has some reversibility, but there are usually residual neurologic deficits. And so I just wanted to spend one last minute talking about the trace elements, which are elements that you need 1 to 100 milligrams of daily, including copper, iodine, iron, fluoride, manganese, and zinc. We touched on copper, iodine, important in thyroid function, iron, obviously important for our red blood cells. Fluoride is important. Really, the only negative side effect is increased risk of dental caries, which dental health is very important, but it's certainly not the same as being unable to ambulate or experiencing severe cognitive decline. And then there's also manganese and zinc. Manganese, while important, there are only case reports of human deficiency. And then zinc, as you may have picked up on, is important, especially in immunologic function as well as wound healing. And so that might be a reason to think about deficiency in your patients. These are just important things to think about in any patient coming in with a history of abdominal surgery, resection of any kind, changes in diet or intake, either because they're of swallowing or ability to eat, or for reasons of weight loss. But important to screen for these, as they can be reversible and have significant impact on quality of life. Any other questions or concerns? Awesome job, guys. And I am going to look into that PPI stuff. Thanks so much. Have a great afternoon.